Yes, sir, you're audible.
Okay, so the topic which I'm going to talk is about the interpretation of PD1, MSI, and TMB in non-small cell lung carcinoma. As we know now, the immunotherapy is a very promising drugs, and which has made a significant impact across many tumor types. But at the same time, it is a very expensive drug, and clinician expect from the pathologist to give us some clue that whether this drug is going to benefit or not. So there are many biomarkers are available, and out of which PD-L1, TMB, and MSI are the more commonly used, and I'm going to discuss them. Starting with the PD-L1, as we know that this is a IST marker which is commonly used in most of the patients before starting the immunotherapy, and it is expected that the tumors which shows a high PD-L1 expression are likely to respond to the immunotherapy as compared to the tumors which show either low expression or no expression for PD-L1. And this why this has been established, it is based on the some trials which have shown that PD-L1 expression across various various drugs combination shows significant response, and out of these drugs, it's very interesting to see that most of them were used in lung cancer. So as we see that there are various drugs and various cutoffs, and so it has made the life of pathologists as well as clinicians very challenging. And there are, because these assays were developed along with the drugs, and even the cutoffs were also decided as per the trials. So in the real clinical scenario, it becomes very difficult. So when we deal with the PD-L1 interpretation and reporting, we have to take it in the 3D combination, like the drug, disease, and purpose for that. And if we go as per the companion diagnostics assay, the FDA approved PD-L1 assays, that is 22C3. There is a specific clone which need to be performed on a specific platform, and the indications are also for specific tumor types, as well as the various cutoffs. So this is it's not just an antibody which is to be reported as positive or negative. It is like a whole solution. And 22C3 DACO Pharma DX is a companion diagnostic assay which is can be used for if you're trying to give a pembrolizumab. So that is a FDA approved drug for non-small cell lung carcinoma. But the problem is that we don't these assays and these platforms are not readily available at all the places, and we need to use them off-label or as a laboratory developed test. So what is the difference between the companion diagnostic and laboratory diagnostic developed test? So if we use these diagnostic kits for any other indication other than which is approved by FDA, or if we alter anything in these assay, it becomes laboratory developed test. Just to cite one example, there are two drugs which are, both of them are FDA approved. One is 22C3 for Pembro, and for Atizo SP142. So if you are using them in for a specific drug, they are companion diagnostic. But if you would like to use SP142 for Pembro, it becomes a lab test. So that's why there is a need to see if there is a harmonization or standardization across these various available assays. And the initial attempts were made in the blueprint phase 1 study, which shows that SP142 is inferior as compared to the other 3 available clones. And subsequently, some other trials has also showed that SP142 is not a ideal antibody to use, especially in the lung, and is now no more used. So the commonly used diagnostic assays are 22C3, which is need to be performed on the DACO Autolink 48 autoimmunostainer, or SP263, which is commonly done, and it has to be done on the Ventana benchmark platform. But as the availability of these platforms is not very commonly used, people started trying other combinations, like using these FDA-approved antibody using Ventana platforms. And this group has established a protocol in which it has been shown that the reproducibility of using the same antibody on the Ventana machine is feasible. And there are some other research work has also showed that if we use SP263 using Ventana and compare it with the companion diagnostic, the reproducibility and the concordance is not as significant if if we use this DACO antibody on Ventana platform. And we are also trying in TMH to use this 22C3 and using a Ventana platform and see the reproducibility in Indian cohort patients. That was about the antibodies which to use. So 22C3 and SP1-263 are the commonly used antibodies. Now coming to the scoring, in non-small cell lung carcinoma, still the TPS is used. And how do you do the interpretation? First and foremost important, we have to see are your satisfactory and whether even the sample is satisfactory for evaluation or not. Then you if they are satisfactory, then you go to next step in which you interpret the staining in the tumor cells. And only if you are doing the CPS, then only you have to look into the immune cells. Otherwise, normally in lung we don't evaluate the immune cells or macrophages. And finally you give the score. So as I mentioned, first you have to look into the controls, and the control tissue which is used is the tonsil. And why the tonsil is used? Because it shows a variable staining, strong staining in the cryptoepithelium and weak staining in the dendritic cells. So it gives it helps to predict the variable staining which is seen in the normal when we deal with the tumor cases. About the how many minimum number of cells you have to see, there should be minimum of 100 viable tumor cells. Only then you should do the evaluation. And next step is about the evaluation of the tumor cells. And this staining is a membranous, whether it is a complete, partial or complete, both need to be taken into account. And you have to exclude the cytoplasmic staining as well as the immune cells when you are dealing with the lung cases. And finally, if you are using a 22C3 antibody, then you have to calculate the TPS, that is based on the tumor cells expressing the PD1 divided by total number of viable cells into 100. So this is how you have to see the expression. If there is a membranous expression, even if it is a weak, that is taken into account. And TPS scoring you should give only if you are using 22C3. Otherwise, just mention that percentage of the tumor cells which are expressing the PD1 if you are using the SP263 antibody clone. So any expression which is more than 1 is considered positive, but high PD1 expression is considered when the TPS is more than 50%. We have to take into consideration that when we see these cases, many times we see a lot of heterogeneity. As you can see, there are areas which are weak positive and strongly positive. So overall score is based, we have to take into account both strong as well as a weak expression. And heterogeneity can be seen across the tumor site, between the metastatic site as well as, and it can PD1 expression can also change if there is a history of any treatment. And another important thing which while interpretation for PD1, we have to carefully see if there is a weak staining and if the surrounding immune cells, if they show the staining, we don't have to count them in the staining. So finally, how do you report the PD1? You have to specify about the nature of the specimen and whether it is a sufficient number of cells are present or not. And along with your results, we have to mention about the type of the clone which we are using and the platform which is being used. just to share our experience of TMH with the PD-L1 expression. So majority of our cases which come, the requests come for the PD-L1, they are from the thoracic or lung cancer, around 66%, and the expression of PD-L1 was seen in around 61% of the cases. So this is one biomarker in which the expression is quite significant, and over a period of years we have seen number of clinical requests keep on increasing. But the positive cases which shows expression more than 50% are only around 22%, which although the overall positivity was around 61%. So the expression was not significantly different between the squamous or adenocarcinoma. Both shows the similar type of expression, and although there are some researchers as compared to some other researchers, the expression in our cohort is slightly on the higher side, but it is also matching with some other groups, and we have used SP263 in our antibody group. So this was about the PD-L1, and moving beyond PD-L1, TMB is another promising biomarker which can be used in deciding the immunotherapy, and it has been used across various tumor types, and especially in the lung. There are many trials in which TMB has been used as a companion diagnostic assay, and these are the commonly used TMB panels. So as you can see, these most of these targeted panels, they are quite large in size, and they cover the TMB in the range of 1. So is TMB better or more reliable as compared to PD-L1? The answer is still not very clear, but it also need harmonization similar to PD-L1, and there is issues related to the panel size used, and hence there is a standardization for TMB is required. How do you calculate the TMB? There are two ways. One is to do the whole exome sequencing or targeted panel. So use of targeted panel is definitely preferred because it also gives the information about the other biomarkers. The panels, we have to very clear when you are seeing a report which mention about the TMB, you need to see is it covering the enough genomic range. Look into the content of the panel and the platform used, as well as so the panel size is one of the most crucial thing which you should look into when you are seeing a report for TMB. Okay. Just a second, my slides are not moving. To see is that there is a variability for the TMB cutoffs which is used in the various trials. As you can see, in some trials the number of mutations were used, and some says the cutoff of like a 16 or 10 as per the foundation. So there is a variability in the cutoffs which also bring some challenges in when you interpret this TMB for the clinical use. For foundation medicine panel, the TMB or the cutoff is used 10, so that is quite widely used. So you can use either more than 10 or less than 10 as a high or low as in a 2-tier system, or some researchers, they also propose that we can use a 3-tier system for evaluation of the TMB. That might be more reliable. Finally, for interpretation, as the bioinformatics plays a very crucial role when you evaluate the TMB, and a smart bioinformatician should be there, and they need to take care of these parameters whenever they are interpreting. So TMB is not as simple and very simple. It's quite complex, and you can fall into into trap anytime if there is error at any of these steps in the TMB evaluation. So there are groups of the patients who may show the high TMB and PDL1, but at the same time there is a no clinical response, as well as there can be some group of the patients which may have a high low TMB but clinical response is there. So it is still not a very reliable, and at the same time now we can use TMB also in the blood, as shown by some trials, and the TMB of 16 mutation per MB was used in Poplar and Oak trials. And finally, about MSI, the role of MSI in lung cancer for immunotherapy is still not established, and if we are to evaluate it, it can be done either by using ISC, PCR, or as a part of NGS panel. The problem with using ISC, because for evaluation of MSI by ISC, you need to perform four ISC markers, and it consume a lot of tissue. So you will not be able to do the routine diagnostic or targeted biomarker testing. So it's recommended to use in a test for MSI using as a part of NGS panel rather than other modality. And finally, about we need to explore the tumor microenvironment and look for the biomarkers beyond PDL1, MSI, and TMB, and multiplex ISCs platforms can provide a role in that. So with this, I conclude my presentation that till date, PDL1 is one of the best validated and commonly used biomarker for immunotherapy, but it still has many diagnostic challenges and related to the cutoff and biomarker and which assay to be used. And although TMB is quite promising, but there is a need for robust standardization and harmonization, and role of MSI is still under investigation. Thank you very much.
Next talk will be by Dr. Navneet Singh. He is a additional professor in Department of Pulmonary Medicine, PGI Chandigarh. His talk will be on first line immunotherapy, how to choose the first line immunotherapy.